Okay, I'd like to welcome everybody here to our seminar for the day. Today, we have a real treat because we have one of our colleagues from DPPA coming in to give a seminar on DPPS on a very timely topic. We have Dr. Eric Wombwell, who's Pharm.D and BCIDS, which is Board Certified Infectious Disease Pharmacist. I had to practice saying that a couple times to make sure I got it right. And a clinical associate professor in DPPA at the University of Missouri, Kansas City School of Pharmacy. Dr. Wombwell got his Pharm.D degree here at UMKC and followed by an ASHP accredited pharmacy residence at the Kansas City, Missouri VA Medical Center. And then he took up a non-tenured clinical faculty position at UMKC in School of Pharmacy, including teaching the doctor of pharmacy students in a variety of courses with an emphasis in infectious disease. So the students who are joining us today from the Pharm.D program will probably have heard from you before, I'm guessing, Dr. Wombwell. I'm really excited that he's here today because the topic he's speaking on is a review of the SARS-CoV-2, that's COVID-19 vaccine landscape. And I think it's particularly timely given that there's been a lot in the press lately about what we're likely to see, when we're likely to see a vaccine. And I think a lot of us have had questions about that and how that might change the course of this pandemic. So I'm really excited to hear from Dr. Wombwell. Dr. Wombwell's been awarded Teacher of the Year awards more than 10 times. And so I'm really excited because this way he can break down the vaccine landscape for me in a way that I can understand. So Dr. Wombwell, thank you and take it away.
Great. Thanks, Dr. Wyckoff. Yes. So really the stimulus for me on this topic was similar to what you described in the sense of there seems to be a lot of information. What had been unclear to me prior to digging deeper was the variety of vaccines that are in trials right now and in production, and felt like I needed my own education on the differences in the vaccines that are out there. And so I've actually put in a little bit of a caveat to this title, which is a limited review of the SARS-CoV-2 vaccine landscape. And the reason that I say that is there's nearly 200 vaccines out there currently, 35 of them in active clinical trials, and then 145 in preclinical trials. So the landscape is broad. It's nearly a galaxy, the landscape that we're looking at here. So we're going to try and take a look at a more narrow view, which is those that are most progressed along the clinical trial timeline. Currently, there are 0 licensed vaccines, not only for SARS-CoV-2, but also just for coronaviruses in general. That includes our historical SARS-CoV-1, MERS-CoV, as well as just the common cold coronaviruses. There are about 4 strains of those. No licensed coronavirus vaccines at this time. So this will be the first of its kind, if and / when approved. This is probably the statement that gets most people a little anxious in regard to the vaccine, which is the warp speed. We hear the terms of race, leader, who's most advanced, and I think it gets people a little bit anxious that it seems like a race, and a question of safety starts to come in to the mind of a normal person. There's also the active group, which is accelerating COVID-19 therapeutic interventions and vaccines. That's another group of private and public individuals trying to work together to accelerate this process as well. So we hear those terms, and it makes us wonder, how is it that we can accelerate a vaccine this quickly? If you look at some historical comparisons, this is from a paper from Funk just this year in June. If we look at polio, about 60 years before vaccine commercially available, Ebola, about 15 years, SARS-CoV-1 and MERS-CoV, still no vaccines on those, and those have been 17 and 6 years respectively, and we're looking at a SARS-CoV-2 vaccine within 12 to 18 months. So that's certainly accelerated, that's certainly warp speed. I believe the fastest vaccine was mumps, and that was 4 years. This will be a fraction of that. So where's the time coming out at? Where are we accelerating at? And I feel like this provides us a little bit of an insight to that. This is from the World Health Organization tracking where the different vaccines are. And what you can see is that the speed is being made up by not performing certain phases of trials with some of these vaccines. So a company may choose to do only a phase 2 trial rather than doing a phase 1 trial. Or they may do a phase 1 trial and then skip to the phase 3 trial. And even using that term skip probably doesn't come across very well for the general public as well as for us as healthcare practitioners. And I think the thing to keep in mind here is that traditionally that phase 2 trial, and I've never been in on any of these drug company trials, but the phase 2 trial, this is really a hedge trial for the drug company themselves before they go in and invest the millions of dollars in that phase 3 trial. This is the trial stage to say, is this actually going to do what we think it's going to do before we start recruiting tens of thousands of patients into a very large study? This is your 100 patients. And the reason that the drug companies have been able to accelerate through some of these phases is because the federal government is providing the funding. They're essentially providing the hedge, they're providing the insurance that if this vaccine doesn't end up being protective, that the drug company themselves is not out the money. So the reason that they're skipping those phase 2 is because they already have a bit of insurance moving into the phase 3. And in addition to that, they've already are manufacturing these vaccines. So the bulk supply is already in process. Again, they can do that in advance of these clinical trials being completed because they have the funding coming from an outside entity. They're not funding that themselves. They will not be out that money directly. That is money that's coming from the federal government themselves. So that's what's allowing for this warp speed. That's what's allowing for this accelerated timeline with these vaccines. So I guess my emphasis here is that we're not giving up safety or efficacy for speed. What's happening there is just the fiscal responsibilities being transferred to the federal government, so the drug company doesn't have to worry about that aspect at this point in time. Quickly, back to the virus itself, SARS-CoV-2. It's a life cycle. When we think about viruses in general, big question mark, are they alive? Are they not? Because prior to getting into a cell itself, it has no ability to self-replicate. It's pretty much just stagnant in the environment that it's present in until it's able to attach to a target cell. This is SARS-CoV-2, COVID, and it's attaching to the ACE2 receptor, and that's what allows for that fusion of the virus inside of the cell itself. Typically, this is a respiratory cell that it is integrating into. And once it's into that cell itself, that's where the RNA strand that's present in the virus, and in this case, SARS-CoV-2 is a single-stranded RNA virus. It just has one strand of RNA. That gets released and then translated through the ribosome in which the proteins for that virus are manufactured. And that new virus is then released and distributed for infection of additional cells. So when we think about this, the importance of this slide is what are the targets? What are the targets for this virus in terms of a vaccine, in terms of protection? Pretty limited. The target is what we all have come to love and know about COVID is that red spike, right? We see the red spike everywhere, and that's the S-spike fusion protein that attaches to the ACE2 receptor on the outside of the cell. And this is, therefore, the target for all the vaccines. They're all targeting this specific protein. And specifically in the pre-fusion conformation. And the reason that we specify that is because prior to fusing to the cell itself, it has a particular conformation, and then once fused to the cell, that conformation changes on that protein. And what we've seen historically with some other vaccines is when we maybe target the post-fusion conformation, the vaccine doesn't work. We really need it to be that pre-fusion conformation of the spike protein, and that's the target for these vaccines. Two overarching approaches to vaccine production that we see currently from companies. The traditional method, which is either isolating the virus or the bacteria, typically bacteria as well, but in this case a virus, and then inactivating that virus either by radiation or chemical or heat, essentially making the virus non-replicating, not able to infect a cell. Or an attenuated virus. What happens here is the virus is still live, but they run it through so many cell cultures of something that's not, say, a respiratory cell, which is the target cell for SARS-CoV-2, that it's unable to actually replicate or attach to a respiratory cell any longer. It's been attenuated. It can't do what it normally does in our body. And then the third approach is virus proteins, where we essentially hack up the virus itself and isolate the protein of interest and insert that protein into a vaccine serum. Those are traditional methods. Those take a long time because we have to isolate the virus. We have to figure out the particular method by inactivating the virus or attenuating the virus or pulling out the particular proteins after inactivation of the virus. In those cases, we're directly delivering the virus and that protein to the immune system. 80 candidates following this approach, and most of these candidates are still preclinical. So the traditional route is the time-intensive route, and we see that with their advancement in clinical trials at this point in time. Nearly every one of these traditional methods are still preclinical animal studies, have not entered into the clinical studies yet. All of the vaccine candidates that are in the phase 3 trials or phase 2 trials are those that are next generation, newer forms of vaccine. These are all based on gene therapy. And again, when you start talking about genes, I think this introduces some just hesitancy, concern, anxiousness from the perspective of your general public, me, other people, when we start looking at this. These vaccines, really interesting. What we're doing in these situations is we're directly delivering either the RNA sequence or the DNA sequence that is specific to the spike protein of SARS-CoV-2 to a cell, and then that cell makes that protein. It doesn't make the virus, it makes that specific protein, and then that protein is then exhibited on the outside of that cell, and there's an immune response to that cell. It's just simply the sequence of that protein, which reduces some of the side effects of concern, et cetera. And this is also becomes a very quick way of vaccine production, because all that needs to occur is identification of that genetic sequence that encodes for the specific S protein, that spike protein. And what's already been made from these drug companies is they already have platforms. They already have a 5' end and a 3' end on an RNA sequence that they can just insert that specific sequence for the spike protein within, and then boom, they've got a vaccine and they're off and running. So this is very, very quick, and that's why I think it was Moderna was able to put their vaccine out into a clinical trial within 42 days of isolating the RNA sequence, or within 42 days of the sequence for coronavirus, SARS-CoV-2, being identified. Very rapid, very quick, because they had already been working on vaccines for SARS-CoV-1 as well as MERS-CoV. So they already knew the type of cleaning that they needed to do for the RNA, for that spike protein, because it's similar in all the coronaviruses, and they could just insert that directly into their base platform that they had been developing already. So very slick, very quick, 30-plus candidates using these gene therapies. Okay, so that's what I want to focus in on with our remaining time, are these newer generation vaccines, in particular those that are into the phase 3 trials. Overall, genetic vaccines, looking at the mRNA vaccine. So what happens here? I kind of already jumped into it because I'm excited. But to come back, and you can see what I'm saying now a little bit closer, is one, what has to be done is the isolation of the genetic sequence for that pathogen and that protein of interest, in this case, the spike protein. Then that sequence is encoded into an mRNA gene. And this mRNA gene can either be non-replicating or self-replicating. In the non-replicating form, it's just the protein itself in this RNA sequence. In a self-replicating messenger RNA sequence, there's some additional proteins inserted into that RNA sequence that will allow for amplification of that protein upon insertion into the cell. So you see a larger potential immune response or a larger potential protective response with that form. What then has to occur is we have to figure out how to get that messenger RNA into the cell. And this is historically the biggest hurdle, is how can we reliably get the messenger RNA into a cell? Because if you think about messenger RNA, this is rapidly degraded physiologically within the body, quick degradation of messenger RNA. So there has to be some kind of vehicle to house this messenger RNA that's going to be stable enough to get the messenger RNA into the cell. And so that's where there's been a lot of progress over just the last several years. So this is really providential timing for us, that just the basic science at this point in history has been advancing in delivery methods. So then once that's delivered, then the cell ribosomes, the cell in which the mRNA has been delivered, then produces the protein, the spike protein in this case, and then the mRNA is degraded due to normal physiologic processes. And that's one of the benefits of these messenger RNA-based vaccines, is that the potential for side effects is pretty minimal because that mRNA is rapidly degraded within hours. Same thing for the delivery method, which is typically a liposomal nanoprotein, nanoparticle. Those also are degraded fairly rapidly. So that's an additional advantage that we're seeing with the messenger RNA-based vaccines. So again, I talked about some of the innovations that have occurred recently. Just for some of our PhD students, things that may be of interest, just optimization of the mRNA sequence engineering itself, so where we can have a longer half-life with that transcript. The protein production is much higher, much more rapid. The ability to rapidly scale up that messenger RNA due to some new processes like clean capping of the RNA, as well as some of the cleaning methods have really undergone a lot of innovations over the past several years. And then the delivery methods, which I elucidated as well. Three main messenger RNA delivery methods: CARTs, CPPs, and LNPs. The CARTs are what we see more typically utilized for cancer therapy, the delivery for some of our tumors. That's where that's being utilized. The ionizable lipid-containing nanoparticles are the primary vehicle for vaccines. And we're going to see that when we look at some of these vaccines here in a second. They're just more stable overall, and that's been the primary vehicle that has been utilized in some of the preclinical studies. So here's an example. Here's an example of one of these messenger RNA vaccines. This is the Moderna product, mRNA 1273. So joint venture Moderna and NIH. It is a messenger RNA sequence for the spike protein of SARS-CoV-2. This is a non-replicating sequence. So simply dependent upon the ribosome of the cell that it's inserted in for making the protein inside of that cell. Again, a lipid nanoparticle is the delivery method. This is a 2-dose series, 28 days apart. That's currently undergoing phase 3 trial with a goal of enrolling 30,000 participants, and they've currently enrolled 25,000 participants. Now, the thing to note here is they're at 25,000, so they haven't enrolled everyone yet, and you've got a 28-day 2-dose administration here. So we're at least another month out before everyone gets their second dose, before everyone's even gotten their 2 doses. And then you typically need about 2 to 3 weeks to test for the immune response after that. So I would say this phase 3 trial in total, still about 2 months out before we would have completion with all the data collected in this study. What we do have available at this point in time is a phase 1 report, preliminary report, which did show seroconversion, which is antibody production in the serum that occurred 2 weeks after the first vaccination. And also importantly, neutralizing antibody activity. And that's one of the things that has really been emphasized in these phase 1 studies, is looking at the presence of neutralizing antibody versus just general antibody production. What we want is an antibody that will bind up that virus and prevent it from fusing with cells, fusing with the respiratory cells. And particularly this came in focused with I can't remember the vaccine, but where there's stimulation of more binding antibodies that helped actual fusion of the virus inside of cells and created a larger immune response and worse infection. So what we're specifically concerned about is neutralizing antibody, which this 2-dose vaccine schedule did show high activation of neutralizing antibody that was initially a little bit low on just the first dose. It's that second dose that gave the higher response for the neutralizing antibody. So that's just important to note with this vaccine. The other thing that we identified in this study that was observed in the study is that the higher dose of the vaccine, the 250 microgram dose, did have a higher incidence of severe side effects, systemic reactogenicity, and because of that, what's being moved on to the phase 3 studies is the 100 microgram dose on this product. Another pretty similar agent, this is another phase 3 mRNA sequence. This one's BioNTech, Pfizer, and Fosun Pharma, BNT162b2. mRNA sequence, SARS-CoV-2 for that glycoprotein, spike protein, similar delivery, the nanoparticle delivery. This is a 2-dose series, but it's 3 weeks apart, a little bit quicker to get to your 2 doses. It's in phase 3. They've got about 30,000 patients enrolled already. Their goal is 44,000 in total. They just expanded out to get more elderly and minority population in, so we can get some additional information on those populations to know whether or not the vaccine is going to be appropriate for smaller populations or special populations. What we have in terms of a phase 1, phase 2 readback is not peer-reviewed at this point in time, so this manuscript not peer-reviewed yet. But what the investigators have published is a comparison of 2 of their products, BNT162b1 and b2. The B1 vaccine was specific to the receptor for the spike glycoprotein, and it was found to have a higher incidence of systemic reactogenicity, which you can see in the 2 charts down here at the bottom. The one to the left is the B1 vaccine, where you can see a higher incidence of the severe reactogenicity, fatigue, fever in that agent, and particularly in the elderly population that was a little bit higher, versus the B2 form, which is specific to the S protein, lower reactogenicity, better tolerated in the elderly population. So because of that, the B2 product is what was moved on to the phase 3 study. Phase 3 study. Pretty quick immunogenicity developed here. It was a little bit lower for folks older than 65. They're 65 to 85 group. But 7 days after the second dose, which is about 28 days into the schedule, the neutralizing activity exceeded titers for patients who had previous COVID. So we can see as high antibody response after the 2 vaccine regimen as someone who had previously developed COVID.
So Eric, what is this number on the x-axis means? Is the percentage of population or the after given the vaccine or what? The 10, 20, 30?
Mm-hmm. Those are the doses, 10
those...
micrograms, 20 micrograms, 30 micrograms, and placebo.
I see.
Yep. Yeah. Great question. Thank you. Yeah. So those are the two mRNA vaccines that are furthest progressed. There's also a DNA vaccine. This one is not in phase 3s, at least in the United States at this point in time. But I do want to cover it just because it's a newer evolving type of vaccine. What happens with the DNA vaccine, similar to the messenger RNA-based vaccine, we identify the gene sequence for the protein of interest. And again, in this case, that would be the spike protein for SARS-CoV-2. And then that gene sequence is inserted into a plasmid. Plasmids are these small chromosomal cassettes that can be inserted into a cell. And again, delivery becomes a little bit of the barrier in this situation. How can we get this plasmid into a cell so that DNA sequence can then be transcribed into a messenger RNA sequence to then make the specific protein for the virus? So this is going to be cool how we get there. So you hold on, wait for the suspense here. What's nice about DNA vaccines is they're more stable than messenger RNA-based vaccines. We talked about how that messenger RNA is rapidly degraded, it's heat sensitive. DNA-based vaccines are not as heat sensitive. They've got a longer shelf life. They're overall a more stable formulation for vaccination than a messenger RNA-based vaccine. So the one that's furthest progressed from a DNA perspective is an Inovio product, INO 4800. And in this case, we've got a plasmid, PGX9501, that encodes for the specific genetic sequence for the spike protein on SARS-CoV-2. So that plasmid is within the vaccine. That vaccine is injected intradermally, which is a little bit different when we talk about vaccines. Usually this is intramuscular administration or sub-Q administration. In this case, it's intradermal. Immediately after the intradermal injection, that site is then shot with electrical pulses from an electroporation device. And what that electroporation does is essentially what it sounds like. It creates pores in the cell membrane by the electrical pulses that are administered, so that DNA plasmid can actually move into the cell itself and then be translated and transcribed into the protein, which is but this is a very specific device for this product. Inovio also has the rights to that product. They are only in the preclinical stage at this point in time. They've started recruiting, the recruitment is completed on a phase 1, phase 2A study. So that they're starting to move that forward, and then they have a phase 3 study that's recruiting in Korea right now. This is also a 2-dose regimen, 28 days apart, stable at room temperature. So if you think about that, that's going to be ideal for some of your third world countries where refrigeration isn't as readily available or just hard to get to areas, maybe rural populations, etc. That's about all I have on that one. Information on it, at least data, pretty hard to get to. All right, last space here is the viral vector vaccines. So again, these are genetic-based vaccines. In this case, the genetic sequence is being put into a virus vector. In most of the cases, it's an adenovirus. And this virus essentially is injected into us, and it attacks a cell and then releases that genetic sequence into the cell itself. This is what the AstraZeneca product is. This is the agent that you probably just heard on the news had to halt its phase 3 trial over in the UK because of a side effect that they needed to investigate further. The basis for this product is a chimpanzee adenovirus, which is just a common coldy type of virus. This simian adenovirus has been genetically modified so that it is non-replicating. And so once that adenovirus enters a cell, it can't replicate itself. That gene sequence has been removed from the adenovirus. And remember, these viruses, they can't replicate on their own outside of a cell. They have to attach to a cell, get into a cell. They release their genetic sequence, and then that cell's machinery makes the new virus. So in this case, we're using this adenovirus, inserting a sequence for the S protein from SARS-CoV-2 into its genetic sequence. It gets into a cell, typically a respiratory cell, releases its genetic sequence. A part of that sequence that's being released is the sequence for the S protein of SARS-CoV-2. The rest of the sequence isn't full enough to make a new adenovirus inside of the cell. So the only thing that gets produced is the spike protein for SARS-CoV-2, and that protein actually ends up getting expressed on the outside of the cell that's been infected. So it essentially changes that cell's conformation to show the spike protein on the outside of it, and then you've got your immune response to that specific type of cell, inducing the antibodies, the neutralizing antibodies in the T cells, etc. Okay, well, what's important to note here is that because it's a non-replicating adenovirus, is you've got to fill your vaccine with a ton of adenovirus, because each adenovirus only has one genetic sequence in it, right? So you're only getting one cell per adenovirus that you inject, which that's where we're going to maybe see some higher incidence of side effects, because you've got a higher amount of vector or virus that a patient is receiving. And because it's true adenovirus, there is about a 12-hour time period of flu-like symptoms that comes along with this. Over to the right, you can see pretty high incidence of reactogenicity, those flu-like symptoms associated with this vaccine. Again, 2-dose series, 28 days apart. Really large study, phase 3 study, 50,000 patients in this one. This is where we've seen the incident of transverse myelitis, which is inflammation along the myelin of the spinal cord. So that's certainly concerning. The reports that I'm seeing now is that it wasn't related to the vaccine. We'll wait to hear from the drug company themselves, but we don't know that yet, but that has resumed. The phase 1-2 study that we do have, no serious side effects identified in the phase 1-2, just the flu-like symptoms. This was compared to a meningococcal vaccine, ACWY serogroups. And you can see here this adenovirus-based vaccine, AZD122, about even up to 50% of patients there having flu-like symptoms or various forms of flu-like symptoms. So this should be an expectation with this type of vaccine, is that flu-like symptoms is going to be present for most everyone. But again, main thing here is that severity was not serious, at least in the phase 1 or 2 study. What they also looked at here was administration of paracetamol, aka acetaminophen in the United States, which did have some reduction in the amount of flu-like symptoms that patients experienced. What else here? We got T-cell responses that peaked at day 14, so really quick T-cell responses. T-cells, just as a reminder, T-cells are the cells that go around and they eat cells that have been infected by the virus. All right, so they're not blockers. They go ahead and eat up the cells that already have virus inside of them that may be replicating virus. So we definitely want to see a T-cell response with these vaccines. And we also see the neutralizing antibody was detected in 91% of patients after a single dose and 100% of patients after their second booster dose at day 28. So both good findings, very promising findings. Okay. I talked about the traditional vaccines already. They're behind. That's why, they're time intensive. That's why they haven't entered into the clinical studies yet. So on these phase 3 trials that are underway, what the heck are we even looking for, right? What's going to make us feel comfortable saddling up for a shot? First, we want to make sure that it's safe. A couple of big things that we're looking at is vaccine-induced immunopathology. We want to make sure that there isn't a large T helper 2 response, which this is what I elucidated to earlier, that we don't actually get the right target, the right protein target. This was manifested in an RSV trial back in the 1960s, where there's a larger immune response and a larger infection response. So we'll be watching for that. But the thing is, in most of the studies that we're seeing that are phase 1, phase 2 studies, they're differentiating. They're testing, is it T helper 1 that we're seeing stimulated, or is it T helper 2 that we're seeing stimulated? And what we're seeing stimulated is T helper 1. So we're feeling good about that. That's being looked at. The other thing that we want to be sure that's occurring from a safety standpoint is that we're seeing neutralizing antibody. That it's not just antibodies in general that are upregulated, but neutralizing antibodies specific against that spike protein. What we get concerned about is upregulation of binding proteins or binding antibodies or fusion antibodies that would actually help or enhance viral integration or endocytosis into cells and could manifest in a larger infection itself. And what we've seen so far in these vaccines is it's neutralizing antibody that's been enhanced, not binding antibody. So again, we're looking at that's being looked at. That's positive. Some of the other things that we will want to keep an eye out on is for the RNA-based vaccines is, are we seeing a lot of fever? Are we seeing an exacerbation of the immune response? And that would be most specific to the lipid delivery molecule itself. Remember, the mRNA is getting metabolized extremely quickly. It's more of the lipid formulation. Those lipids can be associated with fever, and particularly high fever, which would be a concern in a pediatric population. So we want to keep our eye on that. And then with the replication defective viruses, I elucidated to this a little bit, that because they can't replicate themselves, it's one, essentially we're getting one cell per one virus that we're administering, which means we're going to have a large amount of virus that has to be administered in these vaccines. Because of that, there is a concern for a large cytokine response, a large inflammatory response, and we'll just have to, be looking at whether or not there's any incidence of that occurring in these larger trials. And I think the thing to note is that 30,000, 50,000 patients, we may see that, we may not. What the 30,000 to 50,000 phase 3 trials are going to tell us are common side effects mostly. And that's with any drug, any vaccine. What we're looking for are the common side effects. We're typically not going to see the rare side effects pop up in those phase 3 trials. That's going to be what we end up seeing in our phase 4 post-approval monitoring that comes out. So really just looking to see if that happens as a common side effect with these agents in phase 3 trials. From an endpoint perspective, I've talked a lot about seroconversion, neutralizing antibodies, T-cell responses, which it's important to just keep in mind that those antibodies being present, the T-cells being present, that's immunogenicity. That does not tell us about protection yet. And that's what these clinical trials are going to tell us, is whether or not these patients who have an immune response, is that immune response high enough, sufficient enough to actually provide protection? And what these trials are looking at specifically is an endpoint of moderate to severe disease. So what we're not looking at is asymptomatic COVID. We're not looking at mild COVID. That's not going to contribute to our endpoint, which is kind of good news here. What we're most concerned about are patients being hospitalized, getting on the vent, et cetera, where there's a higher mortality rate. And that's what the endpoint for these phase 3 trials is moderate to severe disease. The caveat to that is it doesn't tell us about protection of asymptomatic or mild COVID, which means that these may or may not protect against asymptomatic or mild COVID disease. So just being vaccinated doesn't mean that we're going to have a reduction in transmission necessarily. And I think that's a key point, and that's something that I've kind of learned as I've dug into this further, is just because we get vaccinated doesn't mean it's masks off. It doesn't mean that we're immune. It doesn't mean that I can't transmit if I have asymptomatic or mild COVID. So those hygiene type manners will still need to remain in play. And then herd immunity threshold, that'll be based upon the vaccine efficacy. And so if we end up seeing that there's a 75% vaccine efficacy, there's a reduction or prevention that's identified in the phase 3 trials of 75%. What that means is we'll probably need about 60 to 70% of the population to get the vaccine in order to induce herd immunity. So that's a pretty large population. That's going to take some time. Again, those hygiene requirements will still need to be in play during that time point. And that also means that still 1 in 4 patients could get moderate to severe disease. So again, all the more important that those hygiene methods are still in play to reduce transmission even after vaccine. Other questions that we'll hope to elucidate over time is the durable immunity. How long does this immunity last for? Is it 3 months, 6 months, 12 months, 5 years? That would be great. Coronaviruses typically do undergo higher rates of mutation, though. So that's a little concerning. It's a single-stranded RNA virus, which means there's a lot of mutation that can occur on that RNA sequence. And we've seen fairly good genetic drift already on that RNA sequence for SARS-CoV-2. The silver lining is that the spike protein itself has not mutated. That's our target, which means that vaccine could potentially have durable immunity. That's great as well. All right, so the unknowns, the questions that will remain are how long will it protect? The rare side effects, right? We won't know that coming out of phase 3. We won't know durability coming out of phase 3. We're probably not going to know about special populations, smaller populations like pediatric patients, pregnant patients, folks that are older than 65. We're probably not going to have enough patients in these phase 3 trials to give us sufficient information on safety and efficacy in these patient populations, unfortunately. So those are going to be the unknowns. Those are going to be the areas that require further study before there's just mass vaccination. So that is your limited review of SARS-CoV-2.
Eric, thank you very much. All right.
Yes.
Very much appreciate that. That was very helpful, and I made some notes not only to ask questions, but also for my stock portfolio, because I think that'll be relevant. I'd like to open the floor for questions now. And if you have a question, just unmute your mic and start talking, and we'll start calling out people, okay? Because I can't see everybody.
I have a question. This is Simon here.
Yep.
You said that they're not looking at mild disease. Why is that? Because it seems like, is it just a logistical issue, or because it seems like if it can treat moderate and severe, that it would also be maybe even more effective against mild disease? Or is it just harder to track that kind of thing?
Yeah, it's a great question, Simon. I think the main reason is, so the CDC has said they want something that's more than 50% effective for preventing moderate to severe disease. So they've kind of made that so the drug companies are going to follow along with that. And a part of that is going to be because that's where we're seeing the strain on the healthcare system is the moderate to severe disease. That's where the strain's coming in. And also that's where we see the mortality is in that form of COVID. Now, to your point, though, I think one of the secondary outcomes they're going to be looking at is mild COVID, but it's not going to contribute to the vaccine efficacy. The vaccine efficacy is going to be based on the moderate to severe disease. There's probably more enlightened responses to that, but I don't have a full answer on that for you.
Right, but like you said, the mild disease actually, in terms of spreading, might be actually more important because those are asymptomatic people who are sort of vectors in the community. And even though in terms of strain on the healthcare system, that's not much, their immediate contribution to that is small, their actual contribution in terms of the people they infect. So it could be that the mild cases, protecting against those, would actually have a big impact. But I mean, you raised that very point yourself. So anyway, it's interesting.
Yeah.
Hey, Eric, I have a question for you.
Yeah.
So for the Moderna vaccine, one of the things that's interesting was you were talking about the dosing, and I think it was the 100 mgs versus the 250 mgs dosing, and one of the things you mentioned was that the reaction was pretty significant for that high dose vaccine, thank you. And what's interesting about this is, with an RNA vaccine, you kind of wonder like what the saturation point is. How much RNA are they getting in to produce that reaction? And it kind of seems to me like there's probably a curve in there where you're going to get whatever reaction you're going to get, and if you stick more RNA in there, you're not going to get more of a reaction just because the machinery in the cell is not going to be able to produce more of the protein, right? So it's interesting because they didn't hit saturation with this, and otherwise I think you'd have seen that. And then the other part that's interesting about this is with other, you kind of suspect then, I mean, this is SARS, right? But then if they do this with other viruses in the future, the saturation point might be different, right?
Yeah, and I mean that's the thing with all of this, right? There's so many more questions than answers. Still, we're trying to answer the most important questions first. Can we get a vaccine out there that's safe and works? And
right.
Then, on this preliminary report, we get that information, and then hopefully on these cleaner reports, the finalized reports, we get more of that information as far as here's the trend line, here's where we see that saturation point moving towards. And so to your point, yes.
Yeah. So there's two questions in chat.
Jerry, the point from the immunology point of view, because the skin is very tight, the structure is much tighter than the subcutaneous tissue. And also there are immune cells within the skin, and because the structure can maintain the vaccine at a high concentration because it's much less diffused to other tissue. And also Langerhans cell play a very important role.
Yeah. Yeah, it'll be interesting to see how we get to that. Okay, so there's two questions in chat I want to make sure we get to. One was thoughts on ASHP's announcement on an FDA emergency use authorization for a vaccine. Do you have thoughts about the emergency use authorizations for any of these vaccines? It's a loaded question, right?
At the end of the day, it depends on what the data says, right? And I mean, in its current state, there's not enough data, particularly from a safety perspective. And I think the thing that we have to be cognizant of is how we educate people about what the vaccine's doing. This is the percentage of patients that it's going to protect, or this is the protection rate. This doesn't mean that you can walk around without your mask on. So I mean, that's not answering the question directly, but there's a lot that is dependent upon what these phase 3 studies show, and what's come out in the phase 1 studies thus far is just not enough for an emergency use. And so we'll need to wait. And I think following the phase 3 studies, it's going to be a similar timeline to an emergency use authorization at that point in time anyway. So
great. Thank you. Yeah. And then the second question was, is the molecular mechanism for lipid carrier-inducing fever currently known? Do we know by what mechanism that's happening?
I'm sure it's known. It is not known to this person at this moment in time. If someone knows, I'm happy to share the floor with that individual who knows.
Okay.
So,
JP, go for it.
yeah, one quick question. So, because of the patient or the people who receive the vaccination, and they show very high percentage of patients suffered with fatigue. So any particular mechanism kind of consideration for that, or discuss the like where cytokine plays, very important roles in some way. Maybe we found a model to study fatigue, chronic fatigue. So
yeah. Yeah, I mean, as our immune response increases, what we generally see is this pretty large strain on the sympathetic nervous system, right? It's a stressful situation, which you've got this profound sympathetic response that occurs with a degree of cortisol being released at that point in time, as well as your adrenaline, your noradrenaline that are being released, which typically blunt away from some of our more vital organs. Now, they do push blood towards our skeletal muscle, which we would think wouldn't necessarily be associated with fatigue. But this is just a part of that immune response that we see. Down to the mechanistic point, I'm going to struggle to get there for you, JP.
I got a question for you, Eric. First of all, great talk. Thank you for that. And I'm gonna point out Paul Shaw's question as well, because I want to have you put on your treatment hat back on for a minute. So part of his question was like, which I'm curious about too. Does plasma donation, is that effective treatment for patients? In effect, the vaccine. What do we know on that? And then I'll add is I had my fourth family member, although my wife's aunt, so sort of indirectly related, that's become positive, and I was intrigued by Dr. Fauci's presentation that I watched last night that Dr. Bott reminded us of, and I finally got to it. And he mentioned, I knew glucocorticoids were effective treatment, but he mentioned out the complexity and the nuances related to glucocorticoid treatment with dexamethasone, because he was suggesting early on in the time course it might be very detrimental to have dexamethasone on board when the immune response is kicking up. But later on, in more severe illness, when the cytokine storm sort of takes over, that might be the time period. My fourth family member here is now getting inhaled corticosteroids, and not oral or injected, so topical to the lungs. So my question more specifically is, how does the plasma donation work? And then the second question is, on glucocorticoids, if those are administered topically, I'm wondering if that timing of administration may not be as critical as Dr. Fauci indicated.
Sure. So on the convalescent plasma, what is really difficult with it as far as a treatment regimen is knowing what is a therapeutic amount of antibodies and how many antibodies that convalescent plasma actually has in it. There haven't been any randomized controlled trials, so there's no studies to say convalescent plasma versus no convalescent plasma. What we have is observational studies on the convalescent plasma, which indicate that there may be some benefit, but that's just generalized administration without a comparative group. So one of the things that I think needs to be weighted with that is, sure, there could be benefit, but also what are the antibodies that are being administered within that convalescent plasma? Is there some binding antibodies in that convalescent plasma as well too? Is it not only just neutralizing antibody, but could there also be some of the binding antibody there that could actually induce some further worsening of the infection itself? And so that's a little bit of the difficulty with the convalescent plasma is there's no standard for it, and we don't actually know what's present in it except its antibodies. That's my answer to that one is big question mark. Would like to see something as far as a comparison as a clinician. And then local glucocorticoids versus systemically administered. When we think about it, infection, the thing that we always have to remember with infection is with typical infection, let's see if I can make this work, just showing you this, is we get this initial inflammatory immune response that happens systemically in the serum, which essentially allows for gaps to be created in our endothelial cells that allow white blood cells to then migrate outside of the serum into the infectious area itself. And so we want that initial inflammatory response so that our immune cells can actually migrate to the spot where you've got infection occurring. So that initial inflammatory response, great. What's not good is when that initial inflammatory response remains high, when it extends out. And that's when we start talking about sepsis, which is the sustained inflammatory response that's occurring inside of a patient. And when you have that sustained inflammatory response, those gaps in those endothelial cells and those tissues remain wide and open. This then allows for capillary leak. So you're starting to lose fluid then. You're also starting to create some fibrosis, additional mucus creation. It's just that overall inflammatory response that's overtly profound, that's inappropriate. And so that's why early in an infectious syndrome, steroid administration isn't ideal. But if that inflammatory response stays profound, that's where the steroid becomes therapeutic, is it helps to blunt that down a bit. In contrast, the local administration into the lungs, so you're using your methasones there as well too. Pick your choice, fluticasone, beclomethasone, etc. What we're having there is just a reduction in that mucus in the airway itself, that mucus production into the alveoli space itself, into the bronchial space itself, that simply is going to allow for greater oxygenation delivery and transfer into the blood circulation itself. So that at any point in time becomes appropriate if there's congestion in the bronchioles and alveoli, with very limited amount of that actually entering into the systemic circulation. Yeah.
Eric, I have a question.
Hit me.
So, great talk. Thanks for presenting.
Yeah.
The question is that we all think that if we increase our immunity, you have zinc every day, have vitamin C 1,000 milligrams every day, we may be protected, and that seems to be the general consensus in the population. But Dr. Fauci yesterday said, and I think you partially answered the question, that increasing your immunity is good, but too much immunity is bad. So do you want to comment on that?
Yeah. So yeah, you're kind of referencing vitamin D, zinc, some of these natural products as more of a protective, or even some evidence to reduce, say, the length or duration of a common cold or viral. I don't know that we've got enough information on that is specific to SARS-CoV-2. We do have that for your run-of-the-mill coronaviruses, that there may be some benefit there. And so I don't think we can ever bolster the immune system enough to a specific pathogen necessarily, and we certainly want our immune system to be responsive. We don't want it to be hyper-responsive, and I don't think we would see that with a zinc or vitamin D as far as it being a hyper-responsive effect with taking those daily.
My question was, if it's hyper-responsive, so you kind of boost your immune system, what adverse effects and why would there be?
Yeah. If you had too high of an immune system, that's where we see the hypersensitivity reactions, right? So if you just think about peanut allergies or a drug allergy, that's where we see immunoglobulins over-responding, antibodies over-responding, where you can see the bronchoconstriction, you can see the vasoconstriction, you see the anaphylactic responses in those cases. Now with zinc and vitamin D, what you're seeing with those is zinc has more of just a straight antiviral effect At least that's what's propagated. And with vitamin D, it's more of a contribution to greater enzyme production in your respiratory tract for pathogens. So it's more of a enzymatic upregulation, not an immune system per se, not a humoral immune system response for antibodies, etc.